Welcome to the Mind Meets Medicine podcast, where we believe the future of healthcare is mind meeting medicine. Hi, I'm Kayla, a licensed therapist and founder of a mental health care clinic.
And I'm Dr. Sir, a board-certified psychiatrist.
Together, we will join the fields of medicine and psychology to provide education, elevate guest perspectives, and foster curious, informed conversations. Welcome back to Mind Meets Medicine.
Welcome back.
I'm Kayla.
I'm Dr. Sir.
And today we're going to be talking about a topic that's really near and dear to both of our hearts, multidisciplinary care. And in today's day and age, whether you're working at a hospital, some kind of institution, or private practice, it's really going to impact all clinicians and doctors at every level of care.
Yeah. And I think what we're mostly going to try to address is some of the cultural differences between psychiatrists and therapists, how we can work together, and maybe some barriers that we both noticed in practice. And
like training. I think there's I'll just start with maybe like in your training, what was the role of a therapist in your mind as a part of the treatment for patients?
Oh, that's interesting. Well, so psychiatry residency is 4 years after medical school. And the first 2 years, most traditionally, it's a little bit changing now, but most traditionally and how it was for me is the first 2 years is inpatient, emergency room, lock facilities. And so we actually didn't have any therapists. We had occupational therapy.
Maybe social workers.
Yeah, social workers, but they didn't do group therapy or individual therapy. So when you're hospitalized in a psychiatric hospital, most of the time, I don't think it's probably because therapy isn't billable in the inpatient setting. I don't know that for sure, though. But yeah, I haven't been in an inpatient hospital so far that actually had someone doing one-on-one work with the patients in the hospital. So that's 2 years of really no interaction with people providing therapy. And then in the outpatient setting, our psychiatric clinics are in the medical hospital for the most part. And we know that our patients are going to therapy. We're referring to therapy. But I don't really remember in the third or fourth year of training ever talking to a therapist. Sometimes they would reach out and I would respond back and we'd have a phone call, but I think that was maybe like maybe 4 or 5 times over, I don't know, 1,000 patients in 2 years, wow, perhaps, or something. And I think that, we were pretty it's pretty hard to find out how to reach me if you're not my patient. So it would have taken, because of the system that I worked in, it would have taken the patient giving the therapist my pager, because the patients don't have my email, so they have to give the therapist my pager. The therapist would then have to page me. Then I would have to follow up in like 2 or 3 days to call them, and then we'd have to schedule a time. But then I worked, from 8 to 5, and then we were on call. So it would have to be, 15 minutes at lunch. It was a difficult logistical procedure.
It's really like medical model.
Yeah. Which means that if you're not in the model, then it's really hard to get contact with the other doctors.
And often, at least in private practice or in outpatient settings, the therapist is often the one sending their client into the hospital setting and then struggling to be able to reach who their client is working with.
Yeah, and I would say my memory may be failing me, but I would say that most of the time when I was in the academic hospital setting, a lot of my patients didn't have therapists. Like whatever therapeutic work happened with me, like once a month or once a quarter, because we were, we're a hospital, so everything is a network. So many of them didn't have an insurance covered therapist. And so I think I also remember not really having much communication because they didn't really have therapy. Like I was kind of providing everything, which meant that they weren't getting great support.
Or just that the medical model only for mental health has a lot of shortcomings.
And we didn't provide therapy in the academic hospital in our clinic. Like you couldn't come see a psychiatrist and then see a therapist in the same clinic. It wasn't a service that was offered. So that was also a bit of a failure of the system.
Yeah. Yeah.
I think the only people who had therapists in our setting were seeing us as therapists in like the free clinic, where we would take 2 or 3 cases for a couple of years, or they would see a PhD or psychology student. But if you didn't kind of like somehow find your way miraculously into that, you came for medical care and that's what you got and that was it.
Yeah. Yeah. So not a lot of, in your training, not a lot of experience working with therapists as a part of the treatment team.
In the academic setting, at the VA, it was actually much different. It was a lot of group therapy as far as like making it more accessible. But in the VA, the Veteran Affairs Hospital, I actually had a lot of interaction with therapists. And we would collaborate, and there's a lot that can happen in messaging in teams, and referrals are easy. So that was a much better model for collaborating, and I kind of learned how to navigate in that way. But not many people train where there's a veterans hospital, so that was a unique benefit.
Yeah, yeah.
In the managed care environment, collaboration between a doctor and a therapist on a patient's mental health is extremely challenging.
Yeah.
The way that insurance decides what it will and won't pay for, the amount of like the scheduling logistically, if you're doing 35 or 40 hours, all of your calls are after 5. I've never talked to another, like from a doctor to a doctor.
Yeah.
If I'm talking to a neurologist or a neurosurgeon or a primary care doctor about a patient's care, it is never before 5 o'clock. It is almost always in the evening, on a lunch break, or like at 6:30. So I also think that is a challenge to, like if you're not in that, that's unnatural. If a therapist reach out to me, I'm like, oh yeah, I'll get back to you. This is before I ran my own schedule, thank God. It's like, oh yeah, I can give you a call back at 6:30 in the morning or 7 o'clock at night. Let me know.
Those are the options.
And they're like, I can't, like, what is that? So yeah, it is extremely challenging in that system to like have 2 professionals come together in a reasonable and consistent way to support one patient.
Yeah.
I think when I was in training, our outpatient caseload might have been between, if we added up everything for full time, it's about 50 to 70 per half day. So times that many number of half days in clinic. So we're looking at maybe, if I was in clinic, maybe 4 full days. We're looking at, what is that math? 50 times 8, 400 patients.
100.
So I have, So I'm thinking maybe about 400 patients. And so that's also sorry, I'm like a little bit on a ramble. So then also for all of those patients, we have to do the prior authorizations, the phone calls, the pharmacy calls, refill issues, side effect issues, crisis management. So all of that happens like, I think maybe like 30 minutes of admin per day. So you got to get your call in that, you know?
There's no room.
Yeah.
There's just
That's
no
a nice
room.
way of
There's
putting it.
no room for case conceptualization
Yeah.
with a long-term provider.
Yeah.
You're looking at stabilization. You're looking at triage, trying to get somebody into their next placement. It's temporary. Get them to a place where they can potentially discharge and be safe, and then find some referrals for when they're not there.
Yeah, it's a lot of managing level of care.
Yeah.
And, but I guess as it comes back to the therapist interaction, it was really, in that model, it was really on the therapist to reach out probably more than once, be available early in the morning or late in the evening, and to get whatever information was needed in like 15 minutes.
Yeah.
I talked to a patient's GI doc for something with a bowel issue that we're like co-managing, and our phone call, I think, was maybe like 4.5 minutes, and I felt like I was being and I was being the chatty one. 4 minutes felt like I was pushing it a little bit too much.
I don't know if it's possible for a therapist to have a 4-minute phone call. I really don't think that's in the realm of possibility.
Yeah. You don't really get much other than like, what are you worried about? What are you going to do? And what's the plan? You know?
I think, and I say this in a cheeky way, therapists can be long-winded, and we want to take our time with understanding the breadth of somebody's clinical picture, right? And so if there's a 5-minute window, the therapist is probably just gonna suck up all that time. Yeah. And so, yeah. And maybe we'll get to like what's helpful for psychiatrists to know about on the phone if there is a quick window, but out and in private practice, it sounds like it's much different.
Yeah. I mean, in the sense that I run my own schedule, and which is a extreme privilege. And so if I want to spend 30 minutes or 45 minutes discussing a case because I feel like it's in the patient's best interest, then I just do that. And sometimes it's still after 5. But that's okay. But sometimes
maybe
it's
not after a 15-hour day.
Yeah,
working.
Yeah. And if it's after 5, it's for like 30 or 45 minutes. So it's like, anyway, so it is nice now to feel like the space and the agency and the autonomy to do it in the right way. I know that is not necessarily generalizable for everyone. But I do think what's important about what we're doing in our relationship and our professional positions and our connection is at least trying to model what it could be, and then people can take pieces from that. Yeah. That fits in their current model of care.
Yeah. It's rare to have a multidisciplinary team that regularly checks in with each other outside of crises in an outpatient setting.
Yeah, maybe we could would it be helpful, because I'm curious, like I have a experiential understanding of what therapists want to know from me, but I'm curious, when you're reaching out to a psychiatrist on behalf of a patient, what information are you looking for? Or are you just, is it information or is it relationship?
That's such a good question. I think, so I'll back up a little bit and I'll say that I think there's and this may not be true for everybody, but I do think that there's a perceived hierarchy in, how do I want to say this? Let me think.
I mean, medicine is extremely hierarchical.
Yeah. And with the treatment team, it can, feel like, especially for newer therapists to the field, it can feel like the doctor is the highest on the chain of command, right? And it doesn't necessarily sometimes feel like, well, I've been working with this client for 2 years. I have a really good understanding of what's happening. And now I'm giving them some kind of referral to get assessed for a psychiatrist. And how do I be of most help to the psychiatrist? I think every therapist has had at least one interaction, if not many, where it's been pretty intimidating to speak with a doctor, especially a psychiatrist, and have felt maybe at certain points that it can be very intimidating to reach out to a psychiatrist that you don't know, that your client is seeing, and what does the doctor want to know, and how can the therapist be helpful and not too long-winded, but that therapists have so much information about a client because they work with this person, every week, maybe for years, maybe twice a month for many years, and they're finally seeing a doctor, and the chance of something going wrong feels high. I think a lot of our clients can feel like they've tried something before and it hasn't really worked out, or there's been a side effect and they just stop taking their medication and the doctor never really knew about it. And so for therapists, there's I'll speak maybe just for myself. I feel like when I make a referral to a psychiatrist, the stakes feel really high. I want it to go well. I want the bedside manner really matters. The relationship with the doctor matters because there's more buy-in for a longer term game plan to stabilization. Versus if there's a long wait list to wait 3 months, 3 to 6 months for an appointment, 15-minute appointment, cold, maybe it's virtual and there isn't a lot of relationship building, not on the doctor's fault because we know what they're up against, but that there isn't really a lot of buy-in from the client, then the therapist has some case management to do on the back end in session to follow up about how the medication is going, encourage them to still go back and talk it through, ask for different options, or maybe there's some questions that they could easily, get answered, but that I'm scared to ask.
Yeah. I think once I had more time to do more collaborative care with therapists, I was like, my eyes open to how much work is done before the person even makes it to my office.
Yes.
How much work is done between my visits.
Yes.
And I've just developed an expanding appreciation for that. And, in training, I didn't really come across therapists unless it was like a quick phone call or something. So a matter of what actually is happening in session was based on my own experience training in therapy, but not knowing what other therapists do. So yeah, I was just, speak with a therapist like, I've been working 8 months to like get them to get to this appointment, and I just want to make sure they land in the right place because it's a really vulnerable moment. And if, they've had a bunch of negative experiences, and feels like if there's one more, then they're just going to totally write off psychiatry. There's just so much in the background before the moment when I meet someone.
It's so true. And the therapist is carrying so much of that hope that it'll go well. And that, how many times have I'm just even reflecting right now, have I sat across from somebody and had to say to them, you don't have to like your medical provider for them to still do a good job. That's an awful feeling, to say this relationship matters, our relationship matters, and your doctor could still be doing a really good job and they're still competent, and they may offend you and say the wrong thing. And how can we cope ahead for that?
It's just cope ahead.
And prepare for this for a doctor to ask a really inappropriate question or dismiss something that matters a lot to you.
Yeah. Yeah.
Because they're up against a lot. The doctors are up against so much. I do not envy, having a couple hundred patients a week, all with a high severity and feeling like this is, it's just this never ending, you're never going to get caught up cycle of people who are really, really sick. And as a therapist, it's like finally getting your client to land in a safe environment is everything.
Yeah. 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 And the downside risk feels high. If it doesn't land well, or certainly if they're harmed or then that the patient is the one that loses.
And the therapist is picking up the pieces with them.
Meanwhile, the whole time they're unsupported medically.
Sure. Yeah.
Yeah.
And I think, something that I do appreciate is when doctors are thorough. So something I want to make sure that I'm, when I speak to a psychiatrist and we have limited time, say we have a 10-minute window, I'm trying to say, hey, they've had a thyroid issue in the past. Make sure they talk about what birth control they're on because this has been a big topic. Trying to rack my brain about they've had migraines in the past and this is or they've struggled with an eating disorder. And anytime you bring up weight gain could be a deterrent. So with a side effect of a medication potentially. And is that a reason to not go on a medication that could help you? And so really making sure that there's some important clinical snapshots that are captured.
Yeah. 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 And I think from my end, there's so much revealed in talking to the therapist that's useful diagnostically.
Cool.
What the person comes in thinking that the issue is part of it, and then I'm seeing something else and I think there's something here, and then I talk to the therapist and then they're like, yeah, that's there, but they didn't mention 10 years ago this and this and this happened. I'm like, oh, that totally changes my approach.
Yeah.
And that probably would have happened eventually, but how many more months without that information, without access to that relationship between the patient and the therapist would have gone, that I would have been a little bit adjacent to addressing the real issue.
Yeah. Yeah. And sometimes I've even learned from just basic blood work, how important that is. And if a client is ever worried about, oh, well, I just thought I was going to go in, get some medication, and it was going to be so quick and they didn't prescribe anything. especially I'm thinking even like for ADHD, right? Like, you know,
Mm-hmm.
I thought this was going to be it. And now I have to do all this extra work.
There's a whole process.
There's a whole process.
Yeah.
And that's where therapy can be so helpful.
Yeah.
Because we get to provide some of that psychoeducation on the back end of being like, hey, this is really important that you go get this blood work done, or it is really important that you have your, you know, your teacher, your therapist, or your parent, you know, answer these questions about your developmental history.
Yeah. I can tell now. Like, I can tell when someone's been teed up by the therapist and is also being managed in the background. Because I'm like, all right, you know, this is the workup. We're going to do this and this and this. I'm actually going to send you for an EKG because of some of the things that I'm noticing. And they're like, okay, sounds fine. And I'm like, do you need to know more information about this? Like, no. And I'm like, okay. Where have you heard about this before? Like, oh yeah, my therapist has been spending months talking about, you know, I'm like, I'm ready to go. And I'm like, all right, cool. Versus like someone, they show up and they're like, we do the whole process. They get onboarded. They do all the paperwork. We're in session. We're going through all the history. I provide the treatment plan. And they're like, I actually don't know that I want to do this. And I'm like, oh, okay. That's totally fine. It's interesting to observe, like, you're here, but not ready. And, you know, then we kind of like go back and forth, and it might be months and months, and they disappear. And then they start therapy, and then they come back like 8 months later, you know? So anyways, that's just a long aside to say, now that I've had more experience working with therapists and like patients coming from different referral directions, I'm like, I can tell either, you know, someone's had a lot of experience in medical care, or I can tell when their psychology has been managed and they're like a glide path into medical treatment has been made.
That's so cool.
Yeah.
That's so cool. And like, gives me so much optimism and hope for how therapists are working this, you know, treatment is so many different things. Therapy can be so many different aspects, right? Like, it's the mind, body, soul approach. And just as much as we're encouraging seeing your psychiatrist or finding the right fit for you, we're also saying, and are you able to get 8 hours of sleep a night? And what's impeding that? Are you, what's the quality of your relationships? I love that saying. That's, you know, before you diagnose somebody with depression, make sure they're not surrounded by assholes. How's their job? What's the quality of life? Are they able to see any daylight, or are they just looking at a screen all day? I had a client really recently move their phone from charging next to their bedside, buzzing all night, to putting it in the bathroom and getting an old-fashioned alarm clock and not looking at their phone first thing in the morning when they wake up, and the difference that has made. Those little tiny things. And then if it is, you know, the right time to see a psychiatrist, and we've maybe had a lot of conversations about the potential of going on medication, or going back on medication, or changing the regimen in some way, and they feel a little like, I could see my GP, but I haven't quite gotten it right. What's the importance of seeing a psychiatrist? And I think I really push for it sometimes, that it's really important to see a specialist.
Yeah, it's that's also a big system challenge too. But yeah, I think there's kind of two situations I think of. One is complex, like medical complexity.
Yeah.
Where there's so much happening medically, and then to sort out psychiatrically what's happening, and I think really benefits from a specialist, or having a more significant condition. But the other part that I think about is where the relationship with the doctor is important. So if people are coming in, even if it's a mild or moderate mental health need, and they're just like, yeah, I just need, I have this thing, the internet or my therapist or someone else says I probably should take medication. I just need you to provide me with the medication so the medication can do what the medication does. That's probably fine for primary care. But if someone is coming in and if there's a lot of hesitation or resistance or there's negative experiences with the mental health system or the medical care system, and the relationship with the doctor is as important as the medication itself in facilitating change and transformation, that's when I think seeing a psychiatrist really makes a difference. Now, it's still possible that you may, or, someone may see a psychiatrist in a model that is very medical and you get a very similar distanced experience. But in primary care, you are for sure always going to have that distance because the model is different. But seeing a specialist, seeing a psychiatrist, if you can find the right system for you, can really make a difference because that relationship can really be put to the forefront, which is how I practice and all of my close colleagues practice too.
Yeah.
It's not just like the delivering of the bestowing upon the method. You're coming to me for the method. Here is the method, and now you will be healed. It's actually about how we work together, that the medication is a piece of that as an intervention, but our relationship is also an intervention.
Yeah. Just
like the relationship with a therapist is a massive intervention.
Which it just makes me think of trust.
Yeah.
Trust. You're trusting your providers.
Yeah.
And having a team that cares about you and that wants to see you thrive it's such a privilege.
Yeah.
And that's aware of your story and your traumas and your current circumstances and how it's all at play. And to know that you're safe to be honest, what an amazing, that's the goal always.
Yeah.
Yeah.
Yeah. I've had so many, I can also tell when someone comes to see me and their relationship with their therapist is really strong and trustworthy. Because when they show up, there's obviously nervousness, anxiety, and what is this going to do? But the trust from the therapist translates into the relationship with me.
Yeah.
They're like, yeah, Kayla said that you're good and she trusts you. So I trust you too. And it's like, all right, that's 3 months, 6 months of work done already just to start, it's beautiful.
Well, and I think there's something really mystifying about how psychiatry works. It's not like, here's an antibiotic and your infection will go away. There's a lot of, it's seemingly like, okay, I'll try this, and it's a wait and see. It's not going to be overnight.
And there's some discomfort potentially along the way.
Yeah. And most times there's this waiting game, right? Where you got to wait and see if you'll wait for the, to titrate to a therapeutic dose and you'll go slow. So you might not get the benefits right away. Won't happen if you start on Tuesday. It won't happen by next Tuesday, right? And we live in a really fast-paced culture. I don't think that's a generalization, or just saying that just because we want things right away. We like immediate gratification, especially with our mental health.
Yeah.
And
if I could do it, I would.
Oh, if I could do it, I would.
It'd be
Therapy
awesome.
doesn't work that way, right? There's some
Yeah.
quick tips, but if you're really doing the work, that's just not how it's going to play out in either one of our sessions, right? It's you got to go home. The therapy is only an hour, and then you got to go home and apply it. And then,
which is also a result of medical model intervention, but
right.
That's on the side.
So I say this because I think if a patient comes to you and is already bought in to working with you for 3 months, 6 months, a year plus, then you get to really support them on that journey, and versus, maybe they're resistant up front and you gotta really build that trust.
Yeah. And the relationship also can be a bit deeper and broader, right? If it's not just my time spent with you working on the takeoff with the medication and the turbulence with it, and then hopefully potentially at some point the landing, if it can be about, if a lot of that work has already been done in the therapy relationship, then our relationship can get into more nuanced things. And we can also be a little bit more, I actually feel like in those situations, I can do more intervention medically, because not each one is like such a big bracing. So I can do multiple things at once, and then people actually get better much faster. It'll be 2 or 3 months instead of 6 months or a year, because we can only do one little shift every month, because there's the management of the psychology around the medication is only done between me and the patient. But if it's done with a therapist, it's like we can get so much more done so much quicker, and people really respond. Which is really cool.
I have a question for you. What do you need to know from therapists when a therapist is reaching out to you? What's helpful? If you think they might be a little like, it's unknown, what a doctor needs to know, and maybe they're 5 years in or under, what do you wish that therapists knew?
If I'm thinking about what, like when I'm speaking with a therapist, what I want to know about the patient, the one thing that I for sure want to know is, if I gave your patient a medication and it was magic, what would it do? What
it's a little miracle question.
Yeah. And that oftentimes can kind of cut through some of the back and forth on case formulation or diagnosis, or I say this to my patients too. But I say this to based on your relationship or your experience with them, if a pill was magic, what change or transformation, where are you getting stuck? Then that usually opens it up in a diagnostic direction, in a social environment direction. Maybe it's even like being a co-collaborator and getting them and supporting them in the recovery process from addiction. It may not even be about prescribing. It might be about hearing from a doctor what are the harms of certain substances. So there's so many different things. But yeah, it's the one thing I really want to know in speaking with a therapist is, where is the therapy work getting stuck? Because I see medication as an intervention to facilitate the therapeutic process, as opposed to, I don't know, like a pill that will provide a cure.
Like you said, if there was such a thing. But people get better. It's more, I think the way I see it is, how there's those I forget what those things are called, but there's like somebody on a bike, but the repeating background, and it goes from day to night.
Oh,
and it could be a cartoon, and somebody's we're on this journey of somebody's life, and somebody could be doing really well for a long time, and then life circumstances happen, and mental health gets worse again, and then they could get a little bit better, and then they go through a breakup, or then they have to move, or they lose their job, or they have postpartum, I mean, you name it, right?
Go through a medical illness.
Go through a medical chronic pain. Yeah. Somebody like lose your dog. There's so many things that could just tip us in one way. The state of the world is, I think, really heavy for people right now. And so if we're taking into account as providers what's happening for somebody in real time, and then that's our launching point, that's beautiful.
Yeah.
Okay, so you want to know what therapists, like what would be their kind of, if they were to wave their magic wand and say, what would be different?
Yeah. Where's this patient stuck in their process?
Yeah.
That's the 5-minute version.
That's the 5-minute. Yes.
Yeah.
And then are you curious about, like if you have 100 emails in your inbox, as most doctors do, what do you want to know if you're going to call somebody back or email somebody back?
I mean, if we're in the 15 to 30 to 45-minute range,
yes,
I want to know what's going on in the relationship. I want to know what's going on in the family system, the family dynamics. I want to know if there's anything that I don't need the details, but if there's anything that is probably unrevealed or hidden. And I think duration of treatment is also useful. How long have they been seeing you, but how many therapists before that, and what did they present with as opposed to what has actually been the work done?
Yeah.
Those are, I want to know, I can ask the medical questions, but in my limited time and still kind of monthly, perhaps if it's a special situation, twice a month, but still limited, I kind of want to know what's going on in the inner world of the person, because the medical diagnostic formulation doesn't always give me enough information to know what is the most precise and personalized medical intervention for this person. Even depression, major depressive disorder, right? So like maybe this one thing, but like that shows up in 12 to 20 different ways, and how it shows up, there's, I don't know, a dozen medications I could choose from as a first option. So determining that the person has depression doesn't actually give me enough information. Like I could just pick something random, but if I know more deeply what's going on, then the chance of me getting it right the first time is really high, which means that the person's suffering ends sooner, and their therapy process continues to progress more fully as well.
Yeah, that's cool.
Okay, so Kayla, as a therapist among many therapists, when you are reaching out to a psychiatrist, especially with your experience with a lot of therapist trainees, what is going through the mind of the therapist when they're reaching out and when they're connecting for the phone call? And then maybe I can give you some background about what the kind of medical doctor in the 5 or 10 minute call is looking for information wise.
Yeah. I think this is so important, and I don't want to speak for all therapists, but I will say as a general statement, it can be very intimidating to reach out to a doctor, and therapists don't want to sound stupid or like they don't know what they're doing. They want to sound competent when they speak with a doctor. And so I think there's a lot going on personally for a therapist when we're in those maybe first 20 consultation calls with a doctor and learning what we need to do. And often I will say, like, if you've worked in treatment or if you've worked in a hospital setting or kind of any kind of residential, you'll get really good at your medications. You'll as a clinician, you really can see it and you get to know it. But if you don't have that opportunity, there really isn't another time. You have maybe one psychopharmacology class before you graduate with your master's, and you're really told this is a hard line. You cannot give any feedback, we do not give medical advice, of course, ever. But you're not really taught in school how to coach a client to see a doctor. And why would they want to see a doctor or go on medication? Are you trying to change them? Are you trying to, do they think they're just so problematic that they need medication? And so there's a real nuance to, number one, getting a client in the door of a doctor's office for psychiatric support. And then number two, what happens when the doctor calls you back? What do you say? And that's a real learning curve in the beginning because many doctors are burned out. They have 2 minutes. Outside of the private practice, even in private practice, I would say it's not an interpersonal relationship. They're not trying to be your friend. Versus therapists could get together and go out for coffee and be friends. I don't know if a lot of doctors are trying to find a connection with a therapist. And therapists are a breed of human who's looking for that and looking for validation that they're on the right track. So that's a long-winded way of saying, I think there's an there can be a real, it can be intimidating to speak with a doctor and to be asked something that you might not know the answer to.
Yeah. I mean, I think it's really helpful to know. I mean, I know now, but, especially as a resident in training, like bottom of the totem, even though I'm an attending now, I still don't think of myself as, I don't know, the doctor, it's.
And therapists look up to psychiatrists, look up to the doctor as, we can do the therapy part, but the medications feel so important. So I think
that's still weird to be thought of as being looked up to, but it does seem like that does happen sometimes.
Well, and I think maybe you and I having these conversations evens the playing field that we're all, the focal point needs to be the client. Not taking this evaluation of a full case conceptualization on the phone with a doctor. You don't have most of the time 30 minutes to do that. And it's okay if you don't walk away being friends. That's not the goal.
Yeah.
And that what's the most important things that we need to talk about. And determining, I think asking questions is fantastic for therapists. Like, what would you like me to monitor? What would you like me to watch out for? Could be really great for therapists to know or to be aware of. Like, this side effect could happen, tell me if it does.
Yeah, that's good. I think going into, like, what's on my mind going into taking a call with a therapist is, it's funny because I actually feel, I don't know if intimidated is the right word, but I feel,
like you could be you're playing catch up.
Yeah.
They have, the therapist and the patient already have this established relationship more than what you might already know.
Yeah. Like, my knowledge base is like about, like, going into the call, I'm like, I don't really know this patient. You know this patient. And so I actually feel like I need to create enough security so that you know that I have, like, done a decent evaluation and, like, I know kind of what's going on. But at the same time, I'm also deferential to your perspective because of your training, because of the depth of the relationship, because of the time. So my lean is to put more weight on the therapist perspective than even my own, especially in the beginning. And so when I'm going in, I'm like, I got my notepad out, or I got something up on the computer, and I'm like, I'm about to go to class. This person about to take me to class. They're about to tell me what's up. Like,
I think
about
that's
this
rare.
person.
I think that's like such a nice, like, that should be maybe more of a standard. And I don't know if that's the way the conversations go most of the time.
Yeah. Yeah. And, I can imagine that because I spent most of my life around doctors. So what I would say, aside from me, sir, is that when a doctor, like just the generic, I'm too tired, it's 5:00 and my coffee's worn off, my second coffee's worn off, doctor, going into that conversation, it's like, what's important to know is illness severity. Like, how do you think this person is sick or not sick? Like, that's a big thing in medicine. And so in mental health, like, how severe do you think this person is? Diagnostic, whatever. Do you think there's a safety concern? Do you think, what's their illness severity? What is the most likely what are the most likely diagnoses in your perspective? And is there any resistance? Like, what do you anticipate the resistance to treatment will be?
Yeah.
Those are kind of like the bigger, quick but bigger themes.
Yeah.
If I'm essentially now responsible for this person, I don't really know. Can you tell me, are they safe? Are they really sick? And if they're really sick, that tells me how often I need to see them. And diagnostic probability helps me with my own probability about what the diagnoses may be, and that will change treatment. So yeah, those are kind of some things that I think about.
That's great. I think those are things that clinicians should also be thinking about. So, and I think let's just do like a PSA that therapists call people back. Doctors call people back. I think
both don't sometimes.
And both have a reputation for not for lots of reasons. Not trying to make anybody come at me in the comments.
It's just a human thing.
We're all busy. We're all, being
in mental health is a different type of energy.
Yeah.
Even, it's a different type of energy exchange happening. Yeah. And so managing the logistics of life outside of session, like, I have a lot of grace for.
I do too.
Yeah.
And there is so much to glean from collaborative care and multidisciplinary care. So I really think that this is where the field needs to be trending, with big changes like AI coming and different, we all are going to get different information and maybe even learn from each other. And that's the hope, is that we can all really band together around our mutual client.
Yeah. Yeah. If you're a psychiatrist, call a therapist, especially if your patient's not doing well or something feels weird, call a therapist. If you're a therapist, call a psychiatrist, let them know what's up, let them know what's going on.
Yeah.
Let them know what you're worried about.
Yeah.
And if you're a patient, see if your psychiatrist and therapist are willing to work together, if you have both.
Yeah. It's really easy to sign a release of information and to make this the standard, the gold standard of care. Is for your providers to, it's like the neck talking to the head, right? It's like we want everybody to be connected and on the same page. And especially if there's high acuity symptoms happening. Yeah. We really need to make sure that this is, and it's okay to be the first one to reach out.
Yeah. Yeah.
You know, for therapists, I always say you're not bugging me if it's even another therapist. Like we have, you know, I could have the kid and somebody could have the parents, or I could have the parents and somebody could have them doing couples work, and I could be doing parent coaching. I love to collaborate on cases and to really make sure that we're providing the best care possible.
Yeah. I am still surprised what things are shared with me and what things are shared with the therapist, not consciously. But yeah, it's unpredictable, and
Me too.
It makes a difference to bring each other in.
Yeah. And we're not always asking, you know, the medical questions. And so I've even learned some really important data points about clients that would never normally come up unless I knew from their doctor what was happening. So lots to be learned. Yeah.
Cool. Thanks for listening.
Thanks for listening. We'll catch you next time. Like, subscribe.
Yeah, thanks
Follow.
for joining us. Until next time.
Bye.